Hello, I'm Erica Traxel. I have the pleasure of serving as the Program Director for the Urologic Residency at Washington University in St. Louis. I'm going to be sharing an overview with you all about the Urologic Residency at Washington University. This presentation is intended for those applicants who will be interviewing with us this season. We are very excited to get to meet you all virtually. We're hoping that our presentations can serve as a nice overview for you to get familiar with our division of surgery, of urologic surgery, as well as our residency program in advance of your interview experience with us. My presentation is specifically focused on the residency program. This is one of two presentations that are intended to introduce ourselves to you all. The other presentation is being given by Dr. Gerald Andriel. He is our division chief. I think in terms of order, it would probably be most helpful if you watch his presentation first to give you some background about urology at Washington University, and then watch this presentation. We're hoping that by having this recorded, you guys can see it in advance, and then you can also refer back to it at a later date if you need to refamiliarize yourself with any aspects of our program. So welcome, we're very excited. So I wanted to start off by sharing with you guys who our heart and soul of our program is, that being the residents themselves. I'm going to share with you all their names, their years of training, and also share with you the medical schools from whence they came so that you can appreciate that they are from across the country. And starting off with our chief residents, we've got Dr. Shelley Ogawa, who came from UCLA, Dr. Jonathan Weiss, who is from Washington University, and then Dr. Afan Zephyr, who came from Baylor College of Medicine. Our PGY4 residents include Dr. Yifan Meng from University of Rochester, Dr. Alex Parker from University of Oklahoma, and Dr. Carrie Ronstrom from the University of Minnesota. Our PGY3 residents represent the first year from when we made our transition from 3 residents per year to 4 residents per year. And we remain a 4 residents per year residency, such that ultimately we anticipate having a total of 20 residents. Within our PGY3 year is Dr. Katie Agamawi, also from the University of Minnesota, Dr. Shilpa Argade from the University of Pittsburgh, Dr. Grant Henning, University of Iowa, and Dr. Laura Lee from University of Washington. Our PGY2 residents include Dr. Hassan Al-Kazmi from Duke University, Dr. Nimrod Barashi from Pontificia Universidad Javeriana Facultad de Medicina, Dr. Andrew McLaughlin from Georgetown, and Dr. Nick Pickersgill from Washington University. And then our interns this year include Dr. Helen Kim from East Virginia Medical School, Dr. Connor McCormick from the University of Washington, Dr. Stephen Goh from University of Washington, and Dr. Daniel Wong from UT Southwestern. Wanted to share with you guys who you will have an opportunity to be meeting with your interview experience. We plan on there being a virtual happy hour the Friday evening preceding the Saturday interviews, when you guys will hopefully get a chance to interact directly with our residents, get to learn about them and learn more about our program. So our residents, where do they go? What do they do in the 5 years that they are with us? So this schematic shows you across the years of training the different facilities where they are rotating. And again, I think it would be helpful if you've seen Dr. Andriel's presentation as he shares with you a little bit more about the different locations where we go. And also we have some interactive maps that show where these different locations are as well. So our interns spend half of their intern year on general surgery rotations at our main Barnes Jewish Hospital, and the other half of the year, they spend 6 of the 12 months on our urology service at Barnes Jewish Hospital. In the PGY2 year, this is broken up into 4 different 3-month rotations. 3 months are spent at the John Cochran VA Medical Center. 3 months are on what we call our ambulatory rotation. So we were very excited as we expanded from 3 to 4 residents per year that our residents would have an opportunity to have a dedicated ambulatory experience. We thought it was valuable to have this early on in training so that they can spend time alongside of our attendings getting familiar with what office-based urology is, so that then as they have an opportunity for more autonomy in some of the more resident-run clinics at the VA and within the Center for Outpatient Health, that they would have some basis for understanding to be able to be facile in those clinic settings. Also within the PGY 2 year, they spend 3 months at our main Barnes-Jewish Hospital, acting as the primary point of contact for services that are requesting urologic consultation, whether that be other inpatient services at Barnes-Jewish Hospital or the emergency room. And then 3 months of the year are spent as the junior resident at St. Louis Children's Hospital. So that's where our residents have an opportunity for their pediatric urology experience. In the PGY 3 year, they spend another 3 months at the VA. They spend 3 months on the endourology service, which is based at Barnes-Jewish Hospital. It's just that our urologic service at Barnes-Jewish Hospital is so large that it is split into several different services, one of which is the endourology service. Another 3 months is then spent at Barnes-Jewish Hospital on the what we call main service. Again, it is still all our urologic inpatient service at Barnes-Jewish Hospital. It's just the portion of patients that are assigned to the main service. And then 3 months of the year are spent at Barnes-Jewish West County. So that is a separate hospital. It's about a 20-minute drive from our main campus, where several of our attendings perform both inpatient as well as outpatient surgeries. In the PGY 4 year, so again, that is when we still have 3 residents per year. So the rotation blocks are a little bit different. In the PGY 4 year, 4 months are spent at the VA. 4 months are spent as the acting chief on the endourology service. That resident also has an opportunity to go to Christian Hospital, where several of our attendings have based their practices. And the feedback from the residents, as this is a newer opportunity for them, is that it has been a tremendous opportunity that they have very much enjoyed. And then the PGY 4 residents spend 4 months of the year as the acting chief resident on the pediatric service at St. Louis Children's Hospital. Then in the final year as the chief resident, they are spending 4 months at the VA, 4 months at Barnes-Jewish Hospital as the acting chief resident overseeing the main service at Barnes-Jewish Hospital, and then 4 months of the year acting as the chief resident of what we call the COH service. So that stands for Center for Outpatient Health. That's affiliated with our main campus, and that is a more resident-run clinic in service. The chief resident has an opportunity to really try to make this his or her own experience, to see patients in clinic, to counsel them on their diagnoses and management options. If the patient elects for surgery, then the chief resident is the one who is really acting in the capacity of surgeon, of course with appropriate supervision, and then helping to manage their patients and oversee that service. It's been a very invaluable experience for our residents. So of course, everyone always wants to know, what is call like? And admittedly, at face value, our call system is a rather complicated one, as we're covering different hospitals, different sites. But I think actually the feedback I get from the residents is that they are very happy with our call system, mostly because they were the ones who made it. The way that it is set up now was completely with the input from the residents. They made suggestions as to how best to structure it to make it equitable and well distributed and very livable. So whenever you're at the VA hospital, that is all home call, regardless of level of training. Our residents in their chief year, regardless of which facility they are at, are all serving in a backup capacity. Now that doesn't mean that they have limited responsibilities when they're on call. Actually, it's quite the opposite. So they are the people who are contacted whenever the interns or the junior residents have questions about our inpatients, or if there are add-on surgeries occurring in the middle of the night. Our chiefs are very much actively involved in the management of our service. And then the chiefs for weekend coverage rotate amongst themselves, so that typically they cover one weekend and then are off completely the next 2 weekends. So then for people who are not at the VA and who are not chiefs, we have a bit of a hybrid call schedule. So we used to be all home call at all locations all the time. And it became very apparent that what we called home call in actuality was not so much home call. In particular, our residents, when they were on call for Barnes-Jewish Hospital, not uncommonly were here all night anyways. It's a very busy place. And so in order to be respectful of the need to recover from such an experience, and certainly also being very mindful of ACGME duty hour regulations, we decided that when people are on call during the week covering Barnes Hospital, that it's going to be in-house call, which might not sound so good compared to home call, but it actually has its benefits. So whenever someone is in-house call, that means post-call the next morning after appropriate transition of care, you get to go home. You get to sleep it off. Those are also good days to take care of life, whether it's you need your oil changed or you need to make a run to the grocery store, or if you actually happened to get a good night's sleep on call the night before in a call room, then you might hop over to our simulation center to have some practice on the robotic simulator. And I'll talk about that in a little bit. So in order to more equitably distribute call coverage, given that Barnes-Jewish Hospital and St. Louis Children's Hospital are just across the street from each other, we combined the residents who are at Children's Hospital with the residents who are at Barnes Hospital into one large call pool for those weeknights that they are taking in-house call Monday through Thursday nights. So that way then it's a slightly bigger pie, but it's being divided into lots of smaller slices so that the call burden for any one person is not as great. However, on the weekends, since fortunately a lot of the time life slows down a little bit on the weekends, we then revert to home call. So if you're on call on the weekend and things settle down come early afternoon, we're not going to hold you hostage in the hospital. We want you to go out and enjoy your weekend. You might get called back in, but you might not, and it might end up being a good weekend for you. We also on the weekends separate out our hospitals again so that the residents responsible for Barnes-Jewish Hospital on the weekends are only responsible for Barnes-Jewish Hospital, and the residents who are responsible for Children's Hospital on the weekends are only responsible for Children's Hospital. Another aspect of our call schedule that we started a couple of years ago at the behest of our residents was to begin what we call a power weekend schedule. The idea is the resident who comes on call on Friday nights at 6 p.m. to cover Barnes-Jewish Hospital is the person who remains on call until 6 p.m. Sunday night. So that could be 48 hours of a lot of hard work, but the trade-off is that you then are going to have probably the next 4 weekends free of clinical duties. And our residents, after trying this system, have said that that trade-off is completely worth it. They're willing to work hard for 1 weekend if that means the next 4 weekends they're going to get to be free of responsibilities. Now come 6 p.m. Sunday night, it's a different resident who comes on taking home calls, so that way then the person who was taking the power weekend call gets a little bit of respite before the next work week begins. So like I said, I recognize it's a pretty complicated call setup, but it's one that our residents put together and they're very happy with it. So if you have any questions about it, I'm sure our residents would be happy to talk with you further, and I'm also happy to answer any additional questions you might have about it. So what does every surgeon want to do? Operate. And I think one of the biggest strengths of our program is we operate a lot. So I'm sure you know that everyone is required per ACGME stipulations to log all of the cases in which they participate over the course of their training. This is helpful to make sure that training programs are providing the necessary training for the residents, but it's also helpful for the residents to prepare them for the rest of their lives. And then also whenever they are applying for hospital privileges and credentialing later, and they say, hey, I want to be able to do a robotic partial nephrectomy, and the hospital says, well, how do we know that you're capable of doing a robotic partial nephrectomy? You can produce your case log and show that in spades you had already had a chance to become quite proficient in that surgery. So I looked back at the case logs of our graduated chief residents from the last 5 years to look at their total number of cases that they had logged, and then also to compare the cases that they had logged in each of these different surgical domains to what the required number is per the urology review committee within the ACGME. And then I looked to see by what factor do our graduated chief residents exceed that required number. And so you can see across all of these different domains, our residents far and away exceed these required numbers. Now, one could potentially argue, well, okay, those numbers were historic whenever you had only 3 residents per year, but now you're going to have 4 residents per year. I would counter that by saying, actually, a few years back, we did have 1 year in which we had brought on a 4th resident as a special year. And even including that resident, I believe that class of 4 graduated in 2015. All of them far and away exceeded the required numbers. I would also counter and say, as Dr. Andriel might share within his presentation, we are very much a growing program. We are hiring on new faculty. We are expanding to new sites. We are increasing our patient volume and our surgical volume. And as such, I do not anticipate any potential threats to our resident surgical experience. You know, whenever COVID became a reality in the spring, I think there might have been some programs across the country that were concerned that that might have a significant negative impact upon their residents' surgical experience, as a lot of elective surgeries were brought to a screeching halt. And in early March, I pulled all of our anticipated graduated chief residents' case logs, and every single one of them had already far and away met all of their requirements, and it was not a problem. So I think we've got a lot of volume here. Curriculum. So it's not just doing, it's also learning. And so we have a very intentional curriculum. So over the course of a 2-year rotational basis, we cover all of urology. And this is based on the online AUA University curriculum. And so we make sure that people get all of urology at least twice over then within the context of their residency with us. Every Wednesday morning, we dedicate 7 a.m. to 9 a.m. as our protected educational time. So during that time, our residents, the expectation is that they will be in conference. And we have allied health professionals, physician extenders who help to cover both our inpatient service as well as our consult service so that the residents truly can actively participate in these educational opportunities. So the first hour of conference is typically a broader audience, including the residents as well as faculty and other members of the division. And then the second hour is typically more geared towards the residents. And we rotate this over the course of the month. The first Wednesday of the month, typically we begin with a grand rounds state-of-the-art presentation. The second Wednesday of the month is our monthly morbidity and mortality conference. We have really tried to transform our monthly M&M conference so that we are really looking at it through the lens of just culture, And we are reviewing events in a root cause analysis fashion so that we can identify on a system-wide level what could we do differently, how can we be better for future patients. The third Wednesday of the month is our multidisciplinary cancer conference. So that is when we have input and participation from our radiation oncology colleagues, our medical oncology colleagues, radiology, pathology, and it's a great brain trust where you've got a lot of really smart people trying to figure out how best to take care of some very complicated patients. And then the fourth Wednesday of the month often is an indications conference where we talk about some upcoming interesting cases that are scheduled. So then the second hour is a little bit more flexible. Again, it's curriculum based. Some of the conferences that we have there can be mock oral boards to prepare people for part 2 of the boards, that being the oral boards. And then we also conduct Journal Club monthly. These are the main conference opportunities on Wednesday mornings from 7 a.m. to 9 a.m. But we have a couple of other standing conferences that the residents are welcome to participate in as well. So every Tuesday morning at the Children's Hospital, we have a weekly indications conference where we look at upcoming cases that are scheduled for the next week. And then on Friday mornings, there is another multidisciplinary cancer conference because there's a lot of cancer around here. We additionally have visiting professorships regularly throughout the year. So our longest standing visiting professorship is the Justin J. Cordonnier Visiting Professorship. Began back in 1975, and if you look at the list of names here, there's some pretty big names in the world of urology that have come to us as visiting professors. So we dedicate this day, we set it aside, and our residents are excused from clinical responsibilities. And over the course of that day, we present interesting cases to pick the brain of the visiting professor. They give us some fantastic talks, and it's a great opportunity for our residents to learn much. And then also for us maybe to share with people what Washu is all about as well. This last year, it was Dr. Sam Chang from Vanderbilt who served as our visiting professor right before COVID hit. And so we were able to conduct that visiting professorship in person. We also annually have the John R. Koch Visiting Professorship. So this coincides with the last date of the academic year. That evening is when we have our celebration honoring our graduating chief residents. This visiting professorship began more recently, and the people whom we invite to be our visiting professor is someone who has a prior affiliation with Washington University, whether they're a former resident or fellow or faculty member here. This last June, it was Dr. Peggy Pearl from UT Southwestern who was our Koch visiting professor, and that one was virtual. And so here's a photo of our residents gathered in front of the screen. Even though it was virtual, it was still a fantastic experience. And then we also have a more pediatric focused formal visiting professorship. This one doesn't happen annually, it's a little more interspersed. We're going to be having it again this next year, and Dr. Chris Cooper from the University of Iowa will be visiting with us, probably virtually. I think one of the tremendous resources that our residents have available to us here at Washington University, there's a lot of opportunity for simulation. And with all the technology that we have available to us nowadays, really in an ideal world, people should be practicing these different surgeries in some sort of simulated context before we're doing them on actual human beings. And on campus, we have the WISE lab, a surgical lab that's available to our division and to our residents. So we use that lab space to practice basic surgical skills. So every year, our interns and junior residents at the beginning of the year, we work on suturing, knot tying, instrument handling. We also have lap trainers over there for people who want to become proficient in pure laparoscopic surgery. And then we also have a robotic simulator, which is a very popular place to go. We also had a special occasion earlier this year when there was an SP, a single port simulator that came to the Weiss lab, and our residents had dedicated time to go over there. As part of our ongoing robotics curriculum for our residents, we have an ex vivo porcine lab that we have set up, and our residents on a rotational basis are scheduled to go over there on Friday mornings to practice robotic partial nephrectomy. We also have set it up to be able to practice robotically the vesico-urethral anastomosis as you would for a robotic prostatectomy. So this has been a tremendous resource for our residents. Additionally, about 3 or 4 times a year, we schedule on a Saturday different skills labs. So we recently had a very large endourology skills lab. So on a Saturday morning, we had attendings come in, our residents were there, we had lots of different industry partners who were present. And so our residents had a chance to practice HOLEP. They had an opportunity to practice ultrasound guided percutaneous access like you would for PCNL. Our residents even allowed themselves to serve as the model. Nobody was actually stuck with a needle. No one actually had percutaneous access performed on them, but it was a great opportunity for them. And we also have labs for penile prostheses, urethral sphincters, and slings throughout the year. So why does all this matter? Well, we want to prepare our graduates for independent practice. They're only with us for 5 years, even though that sounds like a long time. It goes by really quickly. And so we want them to be prepared for whatever comes next for them after residency. We want to prepare them for their boards. And I think we've got a pretty good track record in that regard. In the last almost 20 years, only one person failed part 1 of the boards, that's the written portion, but they passed it on their second try. And in that same time span, only one of our graduates has failed part 2 of the boards, the oral boards, and they also passed it on their second try. So I think that's a pretty good track record. And there is life after residency. So a little over half of our graduates in the last almost 20 years have gone on to pursue fellowships, and the other slightly less than a half have gone on to immediately enter into practice afterwards. And getting feedback from both of those groups, they have resoundingly said that yes, we prepared them for the next stage of their lives. For those who have gone on to fellowship, it runs the gamut. We have had plenty of our graduates go into oncology as well as minimally invasive surgery, but really they have pursued all the different aspects of urology, and they have felt prepared for fellowship. Let's talk money. So you get paid to work hard here, and looking at the salaries. So these are the stipends, the salaries that our residents are being given this year. And I think it's a pretty decent salary, especially given the very affordable cost of living here in St. Louis. A lot of our residents, they own their homes, whether that's a house or a townhome or a condo. We've got some who rent also. We've got some who also are able to support a partner and children on their salary. So I think that our residents are pretty well supported in that regard. I would also like to point out that every year our residents get a cost of living adjustment, i.e. a pay raise, and that was the case even this year in spite of COVID. Additional benefits that you might want to know about. So our residents get 30 days of paid leave. So theoretically, people can use this in different ways, but it's suggested that 10 of those days could be used as sick leave. Now, it doesn't have to be your own personal illness. It could be the illness of someone else in your family, say if you have a child. We also have 20 days of other leave within those 30 days then. And so that's where we apply time towards vacation. Our residents each year get 15 days of vacation, and we suggest that people break those up into 3 different 1-week vacations, and we try to ensure that the call schedules are such that your week of vacation is bookended by having the weekend off on either side, so that it's actually a good 9 days that you're totally freewheeling away from work. And then that leaves 5 days for others. So that's where people, if they need to travel to go on interviews for fellowship or jobs, can have some wiggle room. We've had residents in the past who have taken medical mission trips, and they're able to dip into their leave there. Our hospital has also explicitly put out a policy that apart from these 30 days of paid leave, we also have bereavement leave. So if tragedy strikes your family, then you can have 3 days of paid leave away, and that's on top of the 30 days of paid leave. And it's actually 3 days per event. They don't have to be taken consecutively. If you needed 1 day up front, and then a few weeks later needed to use your other days to travel for a service, etc. We want our residents to take care of themselves, and so if you've got a doctor's appointment, you don't have to use a vacation day for that. You know, we want to make sure that there's appropriate clinical coverage so that patients aren't left hanging. But if you need to take off for a couple of hours to go take care of yourself, we strongly encourage that. We also strongly encourage our residents traveling to conferences. So if you've worked hard, you've put together a research project and you've submitted an abstract and it is accepted at a conference that you will get to present at, we want you to reap the rewards of your hard work. And so we encourage our residents to travel to conferences. You don't have to use your leave to do this, and we like to reimburse our residents to cover associated expenses for those conferences. So some other special priorities for our program. We very much are all about patient safety and quality improvement. So we have an electronic event reporting system that we encourage our residents to enter into regularly. Our ERS is reviewed weekly, and we close the loop. We follow up on what happened, and we look to see what sort of systemic improvements we can make for patient care. Again, we conduct our monthly M&M conference in a root cause analysis format. And then our Department of Surgery here at Washington University annually has a symposium dedicated to patient safety and quality improvement. And all of our residents over the course of their training are encouraged to submit to this symposium, to submit an abstract. And we have had many submitted over the years, some of which have even won awards, as you can see in the photo here. In the white coat is Dr. Kifudu, who's now one of our attendings, but he was a fellow at the time, and he submitted an abstract looking at ureteroscopy pathway to try to minimize unexpected patient encounters postoperatively. Other special priorities. So many of our residents in the past have gone on medical mission trips. And you can see some photos of prior graduates. Here on the left is Dr. Tammy Ho performing a TERP in Haiti. On the right is Dr. Michael Glamour performing the first laparoscopic nephrectomy in Haiti. Other special priorities. Wellness, that's become very much a part of the dialogue within medical culture at present, and we take it very seriously. Not just within our urologic program, but across the campus. So our local Graduate Medical Education Council for Washington University, we have appointed a GME Director of Wellness, and we are focused on developing education around topics like burnout, resilience, mindfulness. We administer the Mayo Wellbeing Index annually to all house staff across campus, and we look at the results. It's anonymous, people's responses, but we're able to take the temperature of our institution and also of our program. We also have a wellness committee with wellness champions who focus on concerns like leave policy, food access, our lactation policy and facilities. We also have dedicated mental health resources available to our residents. So our local GME office has a psychologist on staff who is dedicated full-time to our house staff. We also have a physician peer support program if somebody just needs someone else to talk to. And then we try to protect that education to service balance, again, with protected educational time and trying to minimize non-physician obligations. So we've got some nurse practitioners who work with us on our inpatient service and also on our consult service to try to help provide some balance for our residents. Along the lines of wellness, we like to have fun too. So we aim to quarterly have division gatherings. Unfortunately, in 2020, they haven't happened as often as we would like. Although the picture in the upper left there, we all fancied ourselves painters back in February at a wine and painting event. Some of our other events in the past have included escape room experiences, paint gun to vent our pent-up stress and aggressions. And then the upper right corner, that's our local boy band. That was at a holiday party singing karaoke. We also have mentorship groups. So I think that mentorship should be both organic as well as intentional. When I say organic, what I mean is perhaps a resident identifies a faculty member and they say, you know what, I think I someday want to do a fellowship in oncology. And so I'm gonna go talk to Dr. Smith and see what sorts of projects he's working on and help to foster my interest in oncology. But mentorship should also be intentional. And so we have mentorship groups. So we have all of our residents divided into 4 different groups of residents with a faculty mentor. And the residents within the group are stratified across training, meaning the idea is you've got a chief resident, 4, 3, 2, 1, because mentorship isn't just faculty to resident, it's of course also resident to resident. And these groups are encouraged to get together regularly also to talk about work, but also to talk about life. So these are just some photos from some of our gatherings. Pre-COVID, we got together a lot. We hope to again someday soon. So just to talk a little bit about what we envision the Washu Urology brand to be. Who are we? So that way we can look to see who best would be a future addition to our family. So we value innovation and improvement. We are looking to adopt and implement cutting edge technology, surgical techniques, and along the lines of improvement, QA and QI. So looking to see how can we always be doing things better, better for our patients, better for ourselves. We have a commitment to excellence. So we expect each of us individually to uphold this commitment to excellence. As a program, a commitment to excellence, and then for our current as well as for our future patients. So that requires respect and integrity and accountability. And then ultimately, I think we very strongly value teamwork. So our residents and our faculty, we support each other inside of work and outside of work. And I think that that's something that I feel like is very special about our program. I think perhaps the best way to highlight a great example of this was, and this is with permission, one of our residents, Dr. Laura Lee, sent me an email on Sunday night after she had just had her power weekend. Just to take the time to share with me actually what an amazing weekend she had on call. And I think it's the best possible way to really encapsulate the teamwork that we have here. So I just wanted to read it for you guys really quick. She says, "Hi, Dr. Traxel. Wanted to share with you some fantastic moments of teamwork from over the weekend and highlight the interns especially. Daniel's been consistently helpful with a great attitude, joined me in the OR for cases on Saturday, even offered to help with the bedside cysto overnight. He's been ultrasounding kidneys and bladders right and left for his own education. It's a pleasure to be on call with Daniel, and my weekend was certainly smoother because of his help. Similarly, Helen was great this morning on her short day. We did a scrotal exploration and orchiectomy together with Josh the fellow in the backseat teaching role, giving Helen and I both a chance to advance her skills. Helen then helped with the stone case while I went to see 2 new consults. Again, a win-win for us both. She is smart, attentive, and reliable with the floor patients. We are so lucky to have her. Connor also helped, putting in a Coude catheter for a North Campus patient when the oncology nurse was unable to place a regular catheter. I've been impressed with his dedication and attention to detail on the floor. Nick was on call for pediatrics, and we ran into each other in the link at about 2 a.m., both headed to ER consults. I'd gotten 2 ER consults at once and another for a floor patient in acute retention. Nick generously offered his help, and after we settled our ER patients, we tag teamed maybe the fastest bedside cysto and counsel catheter placement possible. Such a morale boost to have a friend in the middle of the night. John was a great chief for the weekend, bringing coffee for me and the intern both mornings, calling me multiple times to check in and see if I needed any help, looking in on the weekend cases and making himself readily available. I'm sitting here on Sunday night feeling so warm and fuzzy about our team and our program, and wanted to pass along those feelings to you. That also gave me the warm fuzzies for sure. And you know, I promise this wasn't staged for this presentation. This is the teamwork that I am so privileged to witness around here on a regular basis. I love our residents, they're great. So I hope this gives you a glimpse into what Washu Urology Residency is all about. This was a division photo from a couple of years ago. I think my favorites are in the middle row. There are 2 of our now chief residents in a prom pose, John and Afan there. But we really can't wait to meet you all in the interviews, albeit virtually this year. And if you have any questions, please don't hesitate either to ask them in the context of that interview or to email us. You'll also get a chance to talk with our residents in the Friday night virtual happy hour, the evening preceding our interview Saturday. So thank you very much for joining us, and we look forward to meeting you soon. Thank you.